Today's topic is osteomyelitis. So I am Dr. Guarang Patel, Assistant Professor at Department of Orthopaedics, New Civil Hospital, Surat. So what is osteomyelitis? Osteomyelitis, it is defined, osteo means bone, myelo means marrow, and itis means inflammation. It is acute or chronic inflammatory process of bone marrow and its structure secondary to the infection with microorganism. So which are the classification of the osteomyelitis? It is basically depend upon the duration, mechanism and host response. Depending upon duration, it might be acute, subacute and chronic. And on mechanism, it may be hematogenous from infection other side of the body, or it may be exogenous, means directly contact from the local site, from like injection or open fractures or any surgeries. And third classification based is the host response. It may be pyogenic, means infective, or non-pyogenic like tuberculous or fungal or anything syphilitic osteomyelitis. And fourth one is Sidney-Mader classification, and it is basically depending upon the location and the physiological type of the host, which will be seen in later slides. So first one is acute osteomyelitis. So it is basically involving infancy and the childhood, means younger patients, and with male predominance. Most common location is metaphysis of the long bone. It is the most fastly growing end of the bone. Predisposing condition like poor nutrition, unhygienic surroundings. So these are the sources of infection like skin abrasion, boil or septic tooth. They leading to the hematogenous spread of the infective foci and the implant at the bone. Infection of the adjacent joint or the soft tissue, it is extension or to the bone. It is directly from the local infiltration or local transfer of the infection. Third one is penetrating wound, open fracture or surgery, traumatic and the iatrogenic implantation. So these are the different sources of the infection leading to the entry of the pathogenic organism in the bone. So which are the etiological agents? Most common infective foci are in infants less than 1 year. Most common is group B streptococci from 1 to 16 years. Means initially in the younger children up to 1 to 4 years, most common agents is the H influenza. And later on it is Staph aureus. More than 16 years or in adults or the young or the older children, it is most common is Staph aureus. And in younger adults, it is most common is the Staph aureus and gram-negative bacteria. So causative organisms, Staph aureus most common, H influenza younger children, but still the most common causative organism for the osteomyelitis in young children is Staph aureus. H influenza has become less common due to vaccination. Salmonella is most common in sickle cell. Pseudomonas most common in IV drug users. Fungal osteomyelitis, it is chronically ill or immunocompromised patients. And in diabetic patients, Candida is the most common organism. So why the metaphysis it is most commonly involved? Because metaphysis is a region of the bone where there are end arteries present, and there is the loophole, there are the hairpin-like arrangement of the vessels. So phagocytic cells, they are fewer, and due to hairpin arrangement of the blood vessels, there is blood flow is sluggish. So there is trapping of the organism there, it is more chances there. So whenever infection foci, it enters at the metaphysis, it leads to the abscess due to the sluggish flow and inflammatory process because of the vascular hyperemia and the exudation of the fluid. So the abscess breaks through the thin metaphyseal cortex, forming a subperiosteal abscess. So acute hematogenous osteomyelitis, which is the pathogenesis. So bloodstream, it is invaded perhaps from minor skin abrasion or a boil or in the newborn from an infected umbilical cord. Any reason, exogenous or endogenous. In adults, source of the infection, it may be arterial line like in the or in the dirty needle and the syringe. So first one is the microbial invasion. Organism usually it settles in the metaphysis. We have seen which are the causes for this settlement of the infective organism at the metaphysis. So highly vascular hairpin arrangement, and it has relatively fewer phagocytic cells and thin cortex. So it is trapped at the metaphyseal vessels. So terminal branches of the metaphyseal artery, they form the loops at the growth plate. They enter the irregular afferent venous sinusoids. So blood flow slowed and turbulent predisposes to the bacterial seeding pus, plus lining cell have little or no phagocytic action made in favorable for bacteria. So first infective foci, it is trapped at the metaphyseal location. You can see in the image foci of the osteomyelitis. So first one, as soon as the infective foci is entrapped in the metaphyseal vessels, it triggers the acute inflammatory reaction, so which causes the vascular congestion, fluid exudation, polymorphonuclear leukocyte infiltration. So this all causes the increase in the intraosseous pressure, which leads to the intense pain and obstruction of the blood flow. So suppression, which is seen on the very second day, pus appears in the medulla and spread along the Walkman's canal, because Walkman's canal, they are the connecting canals between the Hervatian canals. Hervatian canal, they are the end structural canal which is present in each osteon, and they are each Hervatian canal, they are connected with each other with the Walkman's canal. So they are why pus it is spread through this canal, because it is the least resistant locations. So pus, it is from the metaphyseal region, it escapes through the Walkman's canal and they reach up to the periosteum or the end of the cortex to form a subperiosteal abscess. Then they spread along the shaft subperiosteally, and the pus can spread from here back into the bone or into the adjacent joint or into the soft tissue. So in the infants, many often it extends into the epiphysis, because in infants up to the age of the 1 year, physis is not closed, so the metaphyseal and epiphyseal vessels, they are connected with each other. So infection from the metaphysis, it directly goes to the epiphysis and it may enter into the joint, leading to the septic arthritis. So in older children, physis, it is a barrier, because physis, it is fused. So the direct spread, there is no direct spread, but where the metaphysis is partly intracapsular, like in the hip, shoulder or elbow, pus may discharge through the periosteum into the joint. So there are less chances of the septic arthritis in older patients, like more than 1 year of the age, but it may happen in certain location we have seen. So on the second day, when the pus it is formed, so now the stage of necrosis it appears. So it around the end of the first week, because rising of the intraosseous pressure, vascular stasis, infective thrombosis and periosteal stripping, it compromises the blood supply to the bone, resulting in bone death and formation of the sequestra. So as soon as the pressure rises, the supply to the bone, it is not there. So it goes in necrosis and it becomes dead. So up to the end of the first week, there is death of the bone occurs, which leads to the necrosis. You can see in this image, there is the sequestra formation. Sequestra, it is a dead necrotic bone without any vascular supply. So then after, the next stage appears newborn formation. At 10 to 14 days, means end of the second week, newborn forms from the deep layer of the stiff periosteum, because periosteum it has the two layers, outer fibrous and inner cambium layer. So inner layer, it is highly vascular layer and it contains the osteogenic cells. So whenever this periosteum it is stripped off from the cortex by the pus intervening, between these two, still the inner membrane can produce the new cells in response to the infection to separate this infected dead necrotic bone away from the healthy bone. So newborn, it starts forming and it forms alongside the sequestra. It is known as the involucrum. So this is the sequestra in center. And last one stage is the resolution. If infection it is controlled and intraosseous pressure it is released, the bone will heal. If infection persists, the pus may discharge through the perforation in involucrum, which are the multiple holes in the involucrum, which are known as the cloaca. So pus it escapes from this involucrum and it tracked by the sinus to the skin surface. The condition it is now established as the chronic osteomyelitis. This we will also see in the later on in chronic osteomyelitis. These are the series or the pathogenesis of the osteomyelitis. So it is a quick revision: initial site of infection, blood supply blocked, subperiosteal abscess followed by sequestra formation. In response, there is involucrum or a newborn formation. So acute osteomyelitis in infant, we have seen there is no physeal barrier, it is not present, so it can extend into the joint leading to the septic arthritis. Now the clinical features. Initially, patient presents with the high grade fever and child refuses to use his limb. Pseudoparalysis, it is known as the pseudoparalysis, but it is seen in the older children older than 1 or 4 years. In newborn, there is failure to thrive, patient is drowsy, irritable, and on examination there is local redness, swelling, and the local temperature is raised and edema is present. So which are the investigation we would like to advise? Most common, first one is the CBC, there is leukocytosis, WBCs are raised, elevated ESR, CRP, usually CRP it is rapidly raised within 12 to 24 hours and ESR takes 1 to 2 days to rise, but CRP it is rapidly lower down as soon as the treatment begins. So it can be taken as the guarding, it is as a reference for the treatment management. Third one is blood culture. Culture sensitivity by aspiration from the subperiosteal abscess, it is positive in only 50% of the patient with hematogenous osteomyelitis. Now the radiological studies. First one is X-ray. Initial days there is no abnormality seen. You can see only soft tissue swelling, but it might be a hematoma, subperiosteal hematoma, or it might be a pus. But on X-ray we cannot differentiate between these two. By the end of the second week, means the newborn formation, the stage of the newborn formation, there is rare fraction of the metaphysis and newborn formation, then the signs of the healing. So early radiographic signs of the rare fraction of the metaphysis and newborn formation outlining the raised periosteum. So, and you can see only X-ray can diagnose after 1 or 2 weeks, end of the 2 weeks probably, because till that period the newborn or the involucrum has been formed. So you can see 2 parallel cortical lines. Inside one, it is a dead necrotic bone, it is known as the sequestra, it is sclerosed because it is not vascular. So decalcification of the sequestra, it is not occurring. So it looks sclerotic on X-ray, and apart from it, outlining the sequestra, there is newborn, it is formed, which is known as the involucrum. So there are 2 cortical lines you can see on X-ray at end of the 2 weeks. Initially, X-ray cannot help us in diagnosis of this osteomyelitis. So these are the images. First one is the acute osteomyelitis of the ulna in the child. Initial film which is taken 2 days after the onset does not show any abnormality. 2 weeks later, a faint shadow along the radial side of the ulna denotes the newborn formation beneath the raised periosteum. Second one, on the right one, is the osteomyelitis of the femur in the infant. 3 weeks after onset, note the newborn outlining the raised periosteum. The area of the rare fraction in the metaphysis and the epiphysis, the infection spread into the knee joint. So you can imagine how fast it is growing in acute osteomyelitis. So initially, as soon as we suspect any osteomyelitis, we should advise, apart from X-ray, some other investigation which can help in early diagnosis like MRI. Early detection and surgical localization of osteomyelitis, it is sensitivity is 90 to 100. It helps in distinguish between the bone and the soft tissue infection. So MRI, this one lower images is MRI sagittal section, shows the same lesion with the right lesion extending into the growth plate. So MRI is very helpful in initial phase when X-ray cannot diagnose the infection. Radionucleotide bone scanning, it is also have increased activity. So shows increased activity. It can help in diagnosis. So these are the example of this radionucleotide scan. Other one is CT scan. It can used in the complex anatomy, means complex location like pelvis, sternum or calcaneus, spinal vertebral lesion, USG. USG can help in diagnosis of the subperiosteal collection, but it cannot differentiate between the hematoma and the pus. So USG and USG, it is also helpful in USG guided aspiration if we are sending for culture. Now diagnosis. So we have seen the physical, we have confirmed with the physical finding, we have done aspiration with purulent fluid and positive finding on culture, radio imaging confirming the diagnosis. These are the differential diagnosis like rheumatic fever and acute suppurative arthritis. But in rheumatic fever, more than one joint are simultaneously involved and they are more located to a joint itself. While in the acute osteomyelitis, it might be present in the metaphyseal region also. In acute suppurative arthritis, pain and tenderness are same as it is limited to joint. Joint movements are restricted and there is reflective muscle spasm, it is intense. And aspiration reveals the purulent synovial fluid. Now what are the management? First one is the analgesia, because it is a painful condition, so we have to give analgesia to the patient and rest of the affected part, which also helps in the pain management. And we have to give IV fluids because infection, it is associated with the dehydration, so we have to give IV fluids to the patient and antibiotic. IV antibiotics initial for 1 or 2 weeks, then oral for 3 to 6 weeks depending upon the culture and sensitivity. Initially we have to give broad spectrum antibiotics till culture and sensitivity arrives. Now surgery. So if medical management does not help, means the patient it is not improving after the IV antibiotics, means there is some issue. Their pus which has been formed, because pus it is sterile. Antibiotic cannot penetrate into the pus because it is dead necrotic cell, because we have seen the sequestra, it is non-vascular, so it is no blood supply, so antibiotic which we give IV, which it cannot reach there. So we have to remove it by surgically. So what are the surgical management is debridement and drainage. So which are the drainage technique of the osteomyelitis? So whichever the location, we have to open skin subacute and reach to the periosteum. After proper dissection, incise the periosteum longitudinally and gently elevate the periosteum 1.5 cm on each side. If the subperiosteal collection is present, it can come out from this incising at time of the incision of the periosteum. Then if it is pus, it is not drained out, then it might be inside the medullary cavity. So we have to drill hole 4 mm in diameter and we have to remove a small window of the cortex to drain out the medullary canal. Then irrigation of the cavity for at least 3 liter of the saline with pulsatile lavage system. After that, after thorough wash, the wound it is closed with the negative suction and limb it is splinted, because after this procedure, because cortical window has been made, so and apart from the infection and the surgical intervention, bone it might get a pathological fracture, so we have to splinting should be done. And generally 6 weeks of the course of the antibiotic it is given. Now complication. Which are the complication? In initial phase, if infection is not subsided, then it may end up into the septicemia or bone abscess, septic arthritis if it involves the surrounding joint. Then in the late, if it is not appropriately treated, it may convert into the chronic osteomyelitis associated with the pathological fracture, and if the infection it is involving the physis, then it may associated with the growth disturbances. Now the subacute osteomyelitis, it is same as the insidious onset, but as in the acute osteomyelitis there is symptoms which we have seen they are present, they are very mild, and organism being, why this subacute osteomyelitis? Because the organism which is infecting, it might be possibility that it may be less virulent, or patient's host response it is more, or it may be both. Or IV antibiotics it is given initially whenever early infection has been diagnosed. Which are the most common site for the subacute osteomyelitis? Distal femur, proximal and distal tibia. Most common organism is the Staph aureus. Clinical features same: pain, limping, swelling, muscle wasting, and body temperature is usually normal because this subacute is associated with milder presentation. Now Brodie sepsis is one type of the subacute osteomyelitis. In Brodie sepsis, it may be located in metaphyseal or epiphysis, but it is a pure circumscribed round oval opacity which is surrounded by the sclerosis. Most commonly seen in the tibia and the femoral metaphysis. So this is X-ray showing the pure lytic lesion surrounded by the sclerotic margin in the metaphyseal region of the tibia. So it is confirmation, it is the Brodie sepsis. Now investigation same: X-ray, biopsy, fluid aspiration, ESR, WBC, but in this case ESR might be raised but not as high as the acute osteomyelitis. Leukocytosis might be there or it may be normal. So this is it is not a clear picture with this all clinical presentation and lab investigation. They do not direct us in confirmatory diagnosis because they all might be in a normal range. So what is the treatment? First one is immobilization, same as antibiotics, and if it is not responding, then surgical curettage of the lesion and open biopsy. Now the chronic osteomyelitis. So why the chronic osteomyelitis? It happens. In pre-antibiotic era, mortality and morbidity following osteomyelitis was very high, but antibiotics, they have now evolved and they have changed the course of this management. So these are the conditions in which the acute osteomyelitis can convert in the chronic osteomyelitis. First one is failure to suspect correct diagnosis, because we have seen in the pathogenesis how fastly it reacting. Within 1 week end of the 1 week after the infection, it leads in the necrosis of the bone. So initial first 3 to 4 days we have to pick up the diagnosis. If we fail in that, then it may end up into the later diagnosis leading to the chronic osteomyelitis. Second one is failure to perform simple clinical investigation, which we have seen in acute osteomyelitis. They are highly specific and they can guide us in the proper diagnosis. Failure to initiate properly planned therapeutic program, and failure to continue treatment till the disease is eliminated. Now the pathogenesis. Pathogenesis is same as we have seen in the acute osteomyelitis, but in this what happens? The granulation tissue it forms and carries in the osteoblast and osteoclast. The necrotic cancellous bone which is formed at the end of the first week, it is radially absorbed and it is replaced by a new bone. Dead cortex, it is gradually absorbed about its surface, it is detached from the living bone to form a sequestra. What is the sequestrum? It is a piece of a dead necrotic bone which is surrounded by the infected granulation tissue trying to eat the sequestrum away. And it appears pale, having smooth inner surface and a rough outer surface, because outer surface it is surrounded by the granulation tissue. These are the different types of the sequestra. Same, after sequestra has been formed, surrounding living bone attempts to wall off the infection by forming a thick, dense wall which is known as the involucrum. Involucrum, it is the dense sclerotic bone overlying the sequestrum, and involucrum usually has multiple openings because from these openings it is known as the cloaca, through which the exudates, bone debris and sequestra they find the exit and pass through the sinus tract to the surface. So constant destruction of the neighboring soft tissue leading, and the pus escapes from the bone, from the involucrum, from the soft tissue right up to the skin, leading to the formation of a sinus. In the chronic osteomyelitis, sinus it is continually present and it associated with the scanty or more pus discharge depending upon the activity level of the infection. So later on the epithelium, it is inverted and it is so along the track of the sinus. So this image you can see the involucrum, it is a newborn formation, the sequestrum which is non-vascular dead necrotic bone. So this is another image. Inside one is the sequestra, you can see outer border is rough and surrounding bone is the new bone which is known as the involucrum. Staph aureus still most common infective organism. H. influenza, it is culprit below the 2 years. Bacteroids, salmonella in the sickle cell, this we have already seen. Now the Sini-Maeder classification, it is based basically on the two things. One on the anatomical location, second one is on the host response. So depending upon the anatomical location, first one is medullary, means inside the medullary canal. Second one is superficial, so skin subcu up to the cortex but not breaking the cortex. Third one is localized, means same as the second but it also involves the associated with the breaking of the cortex. Fourth one is diffuse, means in localized, if we remove the sequestra or a dead necrotic tissue, the stability of the bone it is maintained. So there is external fixator or any stabilizing device are not required after removal of the dead tissue in third localized type of the osteomyelitis. Fourth one is diffuse, so it is associated with the high bone loss after the debridement leading to the instability which requires the fixation or the stabilization system. And based on the host response, class 1 is the normal, means host response is good. Second one is compromised. Third one is prohibitive, in which the surgical intervention it is more harmful than the disease itself. So same clinical pictures, but in this there are the phases of no active disease in between the active phases. So whenever there are no disease actively present, the patient may be normal. It might have only small sinus tract with or without discharge, but it may be associated with the little pain. So the bone is misshapen, skin is dusky, thin, there is break in the skin may present, muscles are scared and the cause the contracture of the adjacent joint. So pain, it is aching type, usually worsens in the night. Why? Because during the daytime muscles are active, in night muscles are relaxed, leading to the more pain. The overlying soft tissue becomes swollen, and these symptoms are present in active phase. Whenever the infection or the disease is activated, it associated with this warm tenderness over the soft tissue or associated with the collection. The infection progress in a sinus becomes active, associated with the pus discharge. Now the diagnosis. Same clinical diagnosis, laboratory and imaging. The gold standard is to obtain a biopsy specimen of the histological and the microbiological evaluation. So clinical physical examination, so we have already seen but in this we have to assess the bone stability, because in the type 4 where the diffuse involvement of the bone it is present, it is associated with the instability. An evaluation of the neurovascular status of the limb. Lab investigation are usually non-specific because it is a chronically present. So ESR, CRP might be elevated, or WBC is elevated in only 35. X-ray same sequestra it is present along associated with the involucrum, but multiple imaging signs of the cortical destruction, periostal reaction strongly suggest the diagnosis of the osteomyelitis. And in long-standing case of the osteomyelitis, there is cortical thickness, it is reduced. It is associated with the osteoporosis or the osteopenia with multiple moth-eaten appearance. which is not seen in acute osteomyelitis. In acute osteomyelitis, you can see only sequestra associated covering involucrum, but the bone which is not involved, it is healthy and it is normally looking, while in chronic stage, it is also associated with the osteopenia in surrounding bone, and there is multiple patchy areas in the cortex, or which are known as the moth-eaten appearance. Sinography, you can inject the dye from the sinus, methylene blue or anything else. So we can, while operating a patient, we can diagnose the entry of the sinus tract into the bone. So it can guide us how much bone or from which location we have to remove the dead necrotic tissue. Isotopic bone scanning, CT is excellent in diagnosis of the sequestra, and it can also help in the diagnosing the integrity of the bone or the involucrum, because after removing of the sequestra, how much involucrum will be there for supporting the whole bone for the stability of the bone. MRI, it is accurate measure for the pathological insult, and it is superior to the CT in soft tissue evaluation. MRI may reveal a well-defined rim of high signal intensity surrounding a focus of the active disease. It is known as the rim sign. Now, treatment. Which are the goal of the surgery is to eradicate the infection by achieving a viable vascular environment. So, first objective is to remove the all dead necrotic bone or the sequestra. Second objective, to find a method of obliterating any dead space which is left after the debridement. Third one is to obtain a soft tissue coverage. So this should be the main aim of the goal. Removal of infection or infected tissue, followed by dead space management and proper coverage. So the duration of post-operative antibiotics, it is controversial, usually 6 weeks. IV, it is prescribed after the surgical debridement. Now, this is the surgical method of sequestrectomy and curettage for the chronic osteomyelitis. So, one thing you should remember is one must wait for adequate involucrum formation before performing sequestrectomy, because if the involucrum it is not properly formed, then pathological fracture or iatrogenic fracture may occur while doing sequestrectomy. And sinus tract can be injected with methylene blue 24 hours before surgery to make them easier to locate and excise. So, whenever we remove the sequestra, it is followed by the creation of the dead space. So, which are the methods for this dead space management? So, we will see in later slide. These are the different options available for the dead space management, like bone grafting, PMMA beads, local muscle flaps, microvascular transfer, and the ILIZAROV technique. So first one is the open bone grafting. Papanew has been described this open bone grafting, and he suggests the removal of the infection or dead necrotic tissue followed by the external fixation, and he advises this debridement every 3 to 4 days till the infection it is not present and after that he advises the bone grafting of the dead space, most probably from the posterior superior iliac spine, and followed by the soft tissue coverage. Another method is vacuum assisted closure. So it helps in decreasing the edema for the closure of the soft tissue, and it also promotes the formation of the granulation tissue. But disadvantage of vacuum assisted closure is it is associated with chances of bleeding. So this one is the PMMA beads. So why PMMA beads? They are the polymethylmethacrylate antibiotic beads, means they are cements which normally used in the arthroplasty. Because why it is used? Because it is associated with mixture of the antibiotic with the cement powder. So it is commonly used, and it is 200, because it is locally given, it can achieve the 200 times more concentration of the antibiotic at the local site without any systemic side effects. So it can be used for the short term like 10 days, long term and permanent. But the disadvantage is that it requires the removal of the PMMA bits, so it requires associated with the secondary surgical intervention. Third one is biodegradable. It is a newer one in which there are different delivery systems are present, like the bone graft substitute, like calcium sulfate or calcium phosphate. It can be mixed with the antibiotics like the vancomycin, tobramycin. The advantage of this biodegradable delivery system are they do not require the surgical removal. So it is still under the study. Closed suction drain. In this, the drain it is kept inside the bone with multiple holes, and from the antibiotic it is given continuously and associated with on the opposite side suction drain, which helps in the removal of the collection inside the bone. This is another method. Now the soft tissue transfer, it is requires if the very large space it is open. Most common is the tibia. In tibia it is muscle graft from the gastrocnemius or soleus. It is used for the coverage. ILIZAROV technique, when very large portion of the bone has been excised due to infection, there is instability is there and very large bone gap is there, then ILIZAROV can help in the new bone formation. In ILIZAROV, corticotomy, it is performed from the normal bone, and from there this bone segment it is transported towards the opposite side. So this treatment can fill the defect up to 13 centimeter. These are the adjuvant therapies like hyperbaric oxygen, bone morphogenic proteins, platelet-rich plasmas. So which are the complications? Most common is the growth abnormalities, because they are nearly the physes which are the growing ends of the bone. The infective involvement of the physes associated with the growth disturbances, like if it is infected and it is necrosed, then it is associated with the shortening, and in lengthening if it is increased vascularity of the growth plate due to the nearby osteomyelitis. So reactive hyperemia of the hyperemia in region of the physis, it is associated with the lengthening. Second one is pathological fracture. Third one is joint stiffness, muscle contracture, epithelioma, amyloidosis. These are the other complications. So this was all about the chronic osteomyelitis. Thank you.